Yeah, so we conducted a large trial in the United States that I had the good fortune to lead for the National Clinical Trials Network, where we took patients between the ages of 30 and 70 with Ph negative, Philadelphia chromosome negative, B-cell, precursor, acute lymphoblastic leukemia, and we gave them an initial 2.5 months of induction chemotherapy. If they achieved a conventional morphologic complete remission, then we gave them, they continued on study, and we gave them an intensification with high-dose methotrexate and pegosparaginase for CNS prophylaxis. And then at that point, we assessed the status of their disease, and if they were MRD negative by a 6-color flow cytometry assay, we then randomized them to get 4 cycles of consolidation chemotherapy, which is a control arm, or that same 4 cycles of chemotherapy with the addition of blinatumomab, the bispecific T-cell engager molecule. And so they got 4 cycles of blinatumomab, an initial 2 cycles, followed by 3 cycles of the same chemotherapy, then another cycle of blinatumomab, another cycle of chemotherapy, another cycle of blinatumomab, and then patients went on to maintenance therapy. They could go off to an allogeneic transplant if their doctor felt that that was in their best interest, using any donor or any conditioning regimen. And what we showed in that study was that from the time of randomization, the patients that got blinatumomab plus chemotherapy had a 3-year overall survival of 85%, versus the patients that got the chemotherapy, it was 68%. And that was a highly statistically significant difference. The p-value was 0.002. So the addition of blinatumomab in these patients that we tend to think of have a better prognosis because they're MRD negative was still improved with the addition of blinatumomab. We know these patients can still relapse. They can still have small amounts of residual disease that we may not be able to measure. And so the addition of blinatumomab improved survival. And so we think this is a new standard of care for these patients. And in fact, Amgen, the company that makes and provides blinatumomab, went to the FDA and got a new indication for the use of blinatumomab in consolidation chemotherapy based on the results of this study. We did also find that the most benefit was in patients under the age of 55, so between 30 and 55. We saw some benefit above 55, but not as strongly as the younger patients. Interesting, we also found when we looked at a combined cytogenetic and genomic analysis, and we divided the patients into favorable, intermediate, and unfavorable risk, that the blinatumomab provided benefit for the favorable and the unfavorable patients. We didn't see as much benefit for the intermediate patients for reasons I'm not entirely clear of, but we were very encouraged to see the good results, particularly in the unfavorable patients. So we're excited about the results of this study, and we think that it's going to improve survival.